Good evening. Thank you for
Uh,
inviting us to this excellent webinar and great presentations. Dr. Whiteman, are you with us?
yes, can you hear me?
Yes, yes, and I can see you as well. And we have Rosa here, our senior dermoscopist, as well. Dr. Whiteman, as a family physician, how comfortable are you in diagnosing melanoma?
Well, I'm glad you opened up with that question. First of all, I want to thank the speakers who've gone before us because it really sets the stage for what we're about to present here. In my role in teaching medical students and residents in family medicine, as well as working in family practice and working with other physicians, um, I can say that, the comfort level of family doctors in diagnosing melanoma is really not very high. In fact, we gave a talk to a bunch of GPs, and one of the first questions we asked them is, how comfortable are you diagnosing melanoma? And, I don't think a single person raised their hands. And I think this sort of sets the stage in terms of how we're going to handle the epidemic of melanoma that's going to be coming to Canada in the next decade or two. Um, on that topic, Dr. Solomon, I just want to ask when a patient goes to see you, and not you specifically, but say a dermatologist, do they automatically get a full body scan of all the lesions in their body?
In an ideal world, yes, but unfortunately, in practicality, no. With busy practices, dermatologists seeing 30, 40, 50 patients a day. It's not very often that you can do a full exam more than once a year at most, and it's quite time consuming. Dr. Whiteman, how long does it take for you to send a patient to be accepted to be seen by a dermatologist?
So the referral rates, I mean, we've heard from a few people in the chat that they can get in very quickly. I can say that in Quebec, the wait times are about a year, if not longer. And so if you see a lesion that's concerning, it's pretty hard to get expert care. Um, I think maybe what we'll do is we'll jump right into what mole
Let,
scanning
let
looks
me
like.
let me just ask you, sorry,
Yep.
at the MoleScan clinic we've been running for about 3 years. How long does it take to get an assessment?
Well,
Uh,
in our clinic, the assessment, if you call, you can be seen really the next day or certainly that week. I think one of the points that was made in one of the previous presentations is about having to get a referral through your GP to see a specialist. The advantage here is that you can book directly. There is no referral necessary.
for a single
Um,
lesion or for a full assessment, yes.
Yeah, I wanna ask you your impression of the fotofinder technology, the same technology that was presented by Madeline Crawford out of Halifax. I thought maybe we'd just start by showing the viewers exactly how it works. So here we have a patient who's getting scanned, takes different positions, and what you see in the foreground is the photofinder machine. It's very unobtrusive. It's about 6 feet away from the patient and you can see the screen taking all those pictures. Not seen in this video is the dermoscope, which is attached to the computer. That is the same dermoscope that is used by Madeline Crawford in Halifax at Dalhousie. So we have that attached as well, where we can take dermoscopic images. In using this, Dr. Solomon, for the past 3.5 years, what is your impression of this technology?
Well, there's no way of duplicating this. The accuracy, we're mapping every single lesion on the body, and we choose to do dermoscopy with the highest power a digital dermatoscope available. So, there's no way of documenting this in an office on pen and paper or on your EMR. So there's no comparison. I'd like to be able to show my screen and actually show one of our test patients. So where do I get the share screen down here? Okay, share that. Okay, so let's get into.
So just for the audience, this test patient is provided by the PhotoFinder company, so it's not a real patient. It's a
Fotofinder,
model.
yeah, is based in Bavaria, and they're the world leaders in this technology. So you can see on a patient, this is a test patient.
Oh,
When
we don't see your screen actually.
oh, you don't see the screen?
No.
Okay, no, okay, let me just share the screen again. Let's see. Share screen. Share, okay. How about now?
Yep, now we see it.
Excellent. Okay. So you can see that when we do a mapping, which takes about 15 minutes to get a complete mapping, we get a mosaic view of every lesion that's visible to the machine. So there's no bias here. We go through the mosaic view and we look for the ugly ducklings for any of the atypical lesions, just looking at the morphology of the lesions, and then we can see where this is located on the body. Um, with the mapping in 15 minutes, we actually get all these different views. We get complete body views. We get the bottom. We get the plantar surfaces, the palmar surfaces, and all this is on the report. When we look at lesions, we could, look at lesions with high power magnification and choose to do dermoscopy on any lesion we see fits. The whole basis of mole mapping is to get a baseline lesion. So the patient comes in, their first visit, we get a baseline. And if there's any obvious skin cancer, we'll pick it up on the first visit. But the most important thing about this technology is what we're looking for is if a melanoma is actually developing, we're looking for the change in lesions or for any new atypical lesions. So when the patient returns 6 to 12 months later, they actually get into an image, an exact image, a setting where they were placed on the baseline visit. So the machine will pick up any changes in lesions or any new lesions. They actually stand in a ghost image of where they were on each visit. So if we look at two visits, for example, and we compare, this is where the artificial intelligence will actually show us if there's a new lesion. So if you see the red circle here, well, we would see this. We would obviously do a high-powered dermoscopy of the lesion, and most likely this would be a melanoma. So there's no way you could document this without these type of accurate images. You couldn't do this without this technology. We also look for any changes in lesions. A yellow circle will show changes in lesions. So this is how we decide on follow-up whether or not to do high-powered digital dermoscopy. We could also do serial dermoscopy. If we get back and we'd show you the dermoscopic images, then we, for example, look at a dermoscopic image of a lesion. We're looking for changes. So we could bring back a patient in, typically 4 months, and we could compare dermoscopy and see if there are any changes. So there's two components to the artificial intelligence with the fotofinder system. One is the mole mapping, where we can see if there's any new lesions or any change in lesions. And then there's the artificial intelligence on the dermoscopy, where actually on the dermoscopy, on those images, the machine will give us a chance, the likelihood that the lesion is malignant. So in the study, that's what they were actually looking at from a database of dermoscopic images. So so those are the key features, Dr. Whiteman, that we're looking at with the fotofinder technology.
So it's interesting, Madeline Crawford, I did a quick math on her numbers, and I think the pickup rate for melanoma was about 2.5%. In our clinic, and I understand that, it's also biased in the sense that patients self-refer most of the time. I'd say about 70% of patients come on their own. They just find us on Google. Our melanoma rate is 8%. So 8% of all lesions that we 8% of all patients that we see end up having a melanoma, which is really enormous. But it also goes to show really the advantage of people just being able to walk in off the street and get this technology applied to them.
And we're also seeing single lesions. We get very often daily, we get contact, a patient has a lesion, they're concerned maybe a melanoma. So we don't necessarily have to do the full scan. We could do a single lesion as well. And we've picked up lots of melanomas with patients coming in with concern about a single lesion. As we could go through these slides, you could just mention any features that you feel are important. We could see here the machine that we just showed and the distance of the patient from the machine.
So
Uh,
you've practiced for what, 30 years or something like that. And would you say that this is this has changed your practice in melanoma screening?
Oh yeah, first of all, dermoscopy in general, as doing dermatology now without dermoscopy is basically doing it blind. Absolutely. When we talk about ABC criteria, those are criteria that are, more late features in terms of, we're picking up melanomas with features on dermoscopy that don't have any of the ABC criteria just based on, early dermoscopic changes.
Now, what is the smallest size of the melanoma that Palmerston Mole Scan Clinic has picked
We
up?
saw one that was like a millimeter. It was the pathologist was quite shocked actually.
So this technology and the use of dermoscopy enables the pickup of melanomas well before they become
Much
clinically
earlier
relevant.
stages, much greater chance of picking up in situ melanomas because most melanomas will develop de novo on normal skin. 80% will develop on the normal skin, not in a pre-existing nevus. So, the machine's going to pick up any new lesion or change lesion. You couldn't do this without this type of photography. It would be impossible.
Now, what I find curious is the fact that this is not readily available around the world. Can you comment a little bit about its availability in Ontario, for example?
Well, in Ontario, there's probably maybe four clinics in total that are doing this. In British Columbia, there's one or two clinics that I know of. Alberta, I think, has one or two clinics. Um, I don't know about the rest of Canada. Quebec doesn't have this yet. In Europe, it's very frequently used and amongst dermatologists.
People talk often about the patient journey. So once a lesion has been identified as suspicious, what happens?
Well, what we do is each patient gets a report. They get a report sent to them by email that is secure. And we also the patient is contacted and advised of any abnormalities. And then we are associated with a team of plastic surgeons in Ontario and Toronto that are working 6 days a week that do the biopsies and excisions within a few days of the scan. So we're the journey is complete. The patient ends up with the biopsy that's needed. We usually follow the patients at least every 6 to 12 months based on their risk factors. The most important exam of the mole mapping is the follow-up exam. Because if something's in evolution, lesion that is not obvious yet, we're going to see it on the follow-up visit. So the follow-up visits are the most important, obviously.
But if somebody has a melanoma that's evident, would that be diagnosed on the first visit?
If it's an obvious melanoma, yes. If we look at the clinical features that they're obvious, or we choose dermoscopy and we see it on the dermoscopic features, but not necessarily if it's in evolution, you're not necessarily going to pick it up on the first visit.
Now, is this publicly funded? Is this covered by OHIP or RAMQ or other
Not
provincial?
not at this point. There are, I guess, areas of insurance that will cover this under health spending accounts, but it's not covered under government plan yet. But we've seen patients use their health spending accounts for
But insurance companies do cover this.
under I assume under for what we were told under health spending accounts.
Right, right. Okay, so I'm just running through the last slides. I don't know how much time we have left, but I think this is really it's been educational for me just to hear the earlier speakers as well. And thank you, Dr. Solomon, and thank you, Melanoma Canada, for giving us the opportunity. And we look forward to your questions.
Thank you, and thanks Rosa for great work in our clinic and doing wonderful work with our patients.
Yeah, maybe we'll just say a few words about Rosa. She's a certified dermoscopist, and she's the one who actually does the mole scans, the technical aspect of the mole scans for us. and she's been tremendous help. So thank you, Rosa.
He's an active member of the American Dermoscopy Society, International Dermoscopy Society, and is, I consider, a leading dermoscopist at this point.
Wonderful. Thank you both so much.